Welcome to ED Debrief, where data meets the gurney. I am your host, an emergency medicine physician, and today we are doing a deep dive into a topic that, well, honestly, I think it frequently gets misunderstood as a lifestyle choice.
Oh, absolutely. I am a senior emergency medicine consultant, and I can tell you this is not a lifestyle choice. We are talking about a physiological minefield.
Right, and we are treating this session as a true grand round style debrief. We want this to be a shortcut for the medical learner, or really just anyone who wants to know how to spot the invisible killer in the emergency room.
Which is why we are pulling directly from Tintinalli's Emergency Medicine, specifically Chapter 291, covering eating disorders. And to be clear right from the start, we aren't just talking about a psychiatric issue in the abstract.
No, we are talking about mortality.
Exactly. We are talking about the mental illness with the highest mortality rate of literally any psychiatric disorder.
That statistic, the highest mortality rate, it always stops me in my tracks. It frames the stakes immediately for you when you are standing at the bedside.
It really does. And for your board exams, or just for keeping your patients alive in the emergency department, the mission today is to completely shift your mindset. You need to stop thinking, I am treating a skinny patient, and start thinking, I am managing a complex metabolic crisis.
You have to become a clinical decision reviewer. You have to spot the subtle physical signs, understand the terrifying cardiac physiology, and know exactly when you just cannot send them home.
Right. So let us unpack the landscape of this disease, because the stereotype is, you picture the emaciated patient who walks in and explicitly says, I have anorexia.
But the source material suggests that is almost never how it actually plays out.
Rarely. That is the chameleon aspect of this illness. Patients with eating disorders, they present with incredibly vague, non-specific complaints. They come in for dizziness, they come in for fatigue, maybe bloating, or a syncopal episode fainting in the shower.
They almost never present with a chief complaint of an eating disorder.
Never. The eating disorder is the iceberg, and the dizziness is just the tip. And if you aren't looking for the iceberg, you are just going to treat the dizziness with some intravenous fluids and totally miss the pathology.
So to spot it, you really have to understand the classifications, right? Because the text breaks it down into three main buckets.
Yes. And for the boards, you absolutely need to know these distinctions. First, there is anorexia nervosa.
Which most people associate with the restricting type, just pure starvation.
Correct. That is the classic presentation. But there is also a binge eating and purging type of anorexia. These patients restrict their intake significantly, but they also have episodes where they binge or purge.
Which sounds an awful lot like bulimia nervosa. So how do you actually tell them apart clinically?
It usually comes down to body weight criteria, but here is the key crossover concept from the text. Bulimia is not just vomiting. We classify bulimia into the purging type, so that is vomiting, laxatives, diuretics, and the non-purging type.
Non-purging, how does that work?
Well, they might compensate for a binge by fasting for days afterwards or by exercising to just a totally debilitating degree. And the text notes that up to 50% of patients diagnosed with anorexia will eventually develop bulimic symptoms.
So these are not static boxes.
Not at all. They are fluid states of metabolic distress.
Okay, and then there's the third bucket, binge eating disorder, which is very distinct from, say, simple overeating at a holiday dinner.
Massively different. It is characterized by a profound lack of control and immense distress regarding the eating, but, and this is the board exam clincher, without the compensatory behaviors.
So no purging, no excessive exercise.
Right. Just the binge and the overwhelming shame that follows it.
Okay, so we know our enemy, we know the subtypes. Now let us put on our detective hats. You are in the room with a patient complaining of dizziness. The source material describes what it calls a forensic physical exam.
I love that term because it is exactly what you were doing. You start at the top and work your way down. You look at the face. You are looking for a condition called sialadenosis.
Sialadenosis, break that down for us.
It is a painless hypertrophy, so a swelling of the parotid glands. It gives the patient what we sometimes call chipmunk cheeks.
And what causes that?
It can come from chronic starvation, but it is very often linked to the repeated stimulation of the salivary glands during vomiting. It is a telltale sign that something traumatic is happening with the gastrointestinal tract.
Okay, so the face gives you your first clue. What about the hands?
The hands are a dead giveaway if you know to look for it. It is called Russell's sign. These are calluses on the knuckles, specifically on the dorsal aspect of the hand.
Caused by friction, right?
Exactly. It is from the friction of the teeth scraping against the skin during self-induced vomiting. It is quite literally a scar of the behavior. If you see that on a young patient complaining of a stomach flu, your antenna should go up immediately.
That is such a specific forensic clue.
It really is. And then you scan the extremities. You are looking for signs that the body is in energy conservation mode. You might see acral cyanosis.
So blue, cold hands and feet.
Right, because the body is shunting blood away from the extremities to the core just to keep the vital organs alive. You might see brittle nails. And you definitely want to look for lanugo.
Lanugo is that very fine hair, correct?
Yes, this fine, downy hair that grows on the face and arms. It is the body's desperate evolutionary attempt to trap heat because it has lost its insulating fat layer. The body is essentially reverting to a primitive state just to survive.
It is a body in total survival mode. The text also mentions something about orange skin.
Ah, yes, carotenemia. It is not yellow like jaundice. It is distinctly orange. It happens because the body cannot metabolize carotene effectively due to liver dysfunction, or often because the patient is restricting their diet to mostly low-calorie vegetables like carrots.
It is a subtle sign, but once you see it, you know it.
You never forget it.
So let us say these physical signs are subtle, or you are just not sure. The text highlights a specific screening tool that is essential for the bedside, the SKOF questionnaire.
The SKOF is brilliant because it's fast. You do not need a psychiatrist to do this. You can literally ask these questions while you are listening to their lungs. It stands for sick, control, 1 stone, fat, and food.
Let us walk the listener through those.
So S is for sick. You ask, do you make yourself sick because you feel uncomfortably full? C is for control. Do you worry you have lost control over how much you eat?
And O is for 1 stone.
Right, which is a British weight measure. You ask, have you lost more than 1 stone, which is roughly 14 pounds, in a 3-month period?
F is for fat.
Do you believe you are fat when others say you are too thin? And the final F is food. Would you say that food dominates your life?
And how do we score that?
A score of 2 or more indicates a probable eating disorder. It is a massive red flag that tells you do not just treat the dizziness and discharge them. You have to dig deeper.
Because if you discharge them, they might die. And we need to talk about why these patients die. You mentioned this is a metabolic crisis, and the source material puts a huge emphasis on the heart.
The heart is the primary killer here. And it is not just a weak heart in some vague sense. It is a structural failure. When a patient is chronically malnourished, the body catabolizes. It eats its own muscle for energy.
And the heart is a muscle.
Exactly. So you get markedly decreased cardiac muscle mass. The heart literally shrinks. And because of that profound atrophy, you get secondary structural problems. One specific issue the text mentions is mitral valve prolapse.
Now, how does a shrinking heart actually cause the valve to prolapse?
Think about the geometry of the heart. The valve leaflets, the actual tissue of the doors, they stay the same size, but the ventricle holding them gets smaller. The frame shrinks, but the door stays the exact same size.
So it just does not fit anymore.
Right. It does not fit, so the valve prolapses backwards into the atrium. And physiologically, alongside that, you see increased vagal tone. This leads to the classic vital signs of anorexia.
Hypotension and bradycardia. Low blood pressure and a slow heart rate.
Yes. And I want to pause on the bradycardia for a second, because there is a trap here. We see a low heart rate in a young, thin person, and we instinctively think, oh, they must be a runner. They are an athlete.
That is a classic board distractor.
It is a dangerous trap. In an athlete, a heart rate of 45 beats per minute is a sign of efficiency. In an anorexia patient, a heart rate of 45 is a heart that is barely hanging on. It is a sign of impending cardiovascular failure, not fitness.
The text also mentions a specific toxin we need to watch out for. Syrup of ipecac.
Yes. If a patient is using ipecac regularly to induce vomiting, it is directly cardiotoxic. It causes a completely irreversible cardiomyopathy. The heart muscle gets weak and flabby, and unlike the atrophy from starvation, this damage often does not bounce back, even if they stop using the ipecac.
So you have a shrinking heart, a structurally weak heart, and then you have the electrical issues, which makes the electrocardiogram the most critical bedside test.
Absolutely essential. You're looking for QT prolongation. This is a delay in the electrical recharging of the heart. If that QT interval gets too long, the patient is at extremely high risk for a fatal arrhythmia like torsades de pointe.
The text also mentions increased QT dispersion,
which basically means the electricity is traveling through the ventricular muscle unevenly. Some parts recharge fast, some parts recharge slow. That heterogeneity is a perfect setup for sudden cardiac death.
And this electrical chaos is driven largely by the electrolytes, right?
Completely. And the electrolyte pattern actually tells you what the patient is doing. It is like a chemical fingerprint left at the crime scene. If they are purging, meaning vomiting, they lose stomach acid, so you get a metabolic alkalosis.
And they lose potassium and chloride.
Exactly. So you see hypokalemia and hypochloremia, and then the body desperately tries to adapt to this.
By doing what?
Well, the body senses the severe volume loss from the chronic vomiting, so the kidneys crank up a hormone called aldosterone to hold on to water. But aldosterone's mechanism is to dump potassium into the urine to save sodium.
So it actually makes that hypokalemia worse.
Much worse. This vicious cycle is a state called pseudo-Bartter syndrome.
That sounds like a guaranteed board question. Now, what if they are abusing laxatives or diuretics instead of vomiting?
Then the chemical fingerprint changes. You are looking at hyponatremia, so low sodium, and hypomagnesemia. And that hypomagnesemia is particularly dangerous because you cannot fix the potassium deficit until you fix the magnesium deficit first. They are chemically linked at the cellular level.
So we have a patient in front of us with the fragile, shrinking heart and completely chaotic electrolytes. I think a lot of people's instinct would be, okay, let us get some food or an intravenous glucose drip into them immediately. But the text aggressively warns about refeeding syndrome.
This is the paradox of the disease. Telling them to just eat a sandwich is genuinely dangerous medical advice.
Walk us through the mechanism of why that is.
Okay, so the body has been starving for weeks or months. It has switched its entire metabolism to burning fat and protein. Suddenly, you introduce a bolus of carbohydrates. That causes a massive immediate spike in insulin.
And insulin's job is to drive things into the cells.
Right. Insulin drives glucose into the cells, but it acts like a bus. It forces phosphorus, potassium, and magnesium into the cells along with the glucose. Now remember, the patient is already profoundly depleted of these total body stores.
So when the insulin pushes what little they have left in the blood into the cells.
The serum blood levels crash to near zero. And without phosphorus in the blood, you cannot make adenosine triphosphate. You have no ATP. No cellular energy currency at all.
Which means the muscles stop working.
The diaphragm fails, so you get respiratory failure. The heart muscle fails, so you get acute heart failure. The red blood cells break apart. It is a catastrophic multi-system crash.
This is why refeeding has to be an incredibly slow, medically monitored process.
Yes, you are literally walking a physiological tightrope.
It is amazing how systemic this all is. We have talked a lot about the heart, but the complications go way beyond just the cardiovascular system. The text lists an entire section on gastrointestinal disasters.
It is a very accurate term. The gut just stops moving. You get severe gastroparesis. You can get acute gastric dilation where the stomach expands so much it risks rupturing.
And from the physical trauma of the purging.
You see Mallory Weiss tears in the esophagus from the violent force of vomiting, or in the absolute worst case scenario, Boerhaave syndrome.
That is the full thickness rupture, right?
Yes, a complete rupture of the esophageal wall. Air and gastric fluid leak directly into the chest cavity. That is a surgical emergency with an incredibly high mortality rate.
The text also brings up the term cathartic colon.
That comes from years of chronic laxative abuse. The colon eventually just becomes an inert, flaccid tube. It completely loses its normal autonomic ability to contract. You will also see melanosis coli, which is a dark pigmentation of the colon wall that you can see on a colonoscopy.
What about the endocrine system? The hormones must be in total chaos.
They are. And there is a massive trap here for the clinician called euthyroid sick syndrome. You run a basic thyroid panel on this patient, and you see the thyroid stimulating hormone is normal or low, and the T3 is very low.
So it looks exactly like hypothyroidism.
Right. So the reflex is to prescribe thyroid replacement medication. Do not do that. It is a protective starvation response. The body is intentionally dialing down the basal metabolic rate to conserve what little energy it has.
So if you give them thyroid hormone,
You are revving the engine of a car that has no gas in the tank. You drastically increase their metabolic demand and accelerate the catabolism. You will hurt the patient.
treat the malnutrition and the thyroid fixes itself.
Exactly.
We also have to mention the bone density issues.
Yes, this is critical. The starvation leads to hypothalamic amenorrhea, the complete loss of menstrual cycles. That causes a profound estrogen deficiency, which then leads to severe osteoporosis and pathological fractures, very often in 20-year-old patients.
And the real tragedy there is that it is permanent.
It is. Unlike the heart or the thyroid, which can recover, this bone loss is largely irreversible, even if they fully recover from the eating disorder.
That is incredibly sobering. Okay, so we have assessed the patient. We see the subtle signs. We understand the terrifying physiology. Now we face the ultimate disposition decision. Do they stay in the hospital or do they go home? The source material details the admission criteria.
And this is where you cannot just rely on your clinical gut feeling. There are hard, objective numbers, the rule of numbers, derived from the Society of Adolescent Medicine and the psychiatric guidelines that absolutely mandate hospitalization.
Let us run through those hard numbers for the listeners.
First is the heart rate. If it is less than 40 beats per minute in an adult or less than 50 beats per minute in an adolescent, they are admitted. No argument.
What about blood pressure?
Less than 90 over 60 millimeters of mercury for adults or less than 80 over 50 for children. That indicates the cardiovascular system is actively failing to maintain basic organ perfusion.
Temperature is next.
Hypothermia. A core temperature of less than 97 degrees Fahrenheit. That tells you they have completely lost the physiological ability to thermoregulate.
And for the laboratory values?
A potassium level less than 3 milliequivalents per liter. That puts them directly in the fatal arrhythmia danger zone. Or a blood glucose of less than 60 milligrams per deciliter. That is hypoglycemic brain failure.
What about their actual weight? I feel like that is the one metric everyone focuses on.
It is important, but it is just one piece of the puzzle. Generally, if they are less than 75 to 85% of their ideal body weight, that warrants admission, or perhaps more importantly, acute food refusal. If they are in the emergency department and they simply will not eat or drink anything, they cannot go home.
And we cannot forget the psychiatric criteria for admission.
Suicidality. We have to remember that the suicide risk is 6 times higher in anorexia than in the general population. If there is active suicidality or a complete lack of motivation to cooperate with outpatient treatment, that is an automatic admission. You cannot discharge a patient who is actively trying to die, whether that's by suicide or by starvation.
It is a heavy checklist, but it provides absolute clarity for the clinician. Now, before we wrap this deep dive up, we need to cover the pitfalls, the special populations that we might miss because they do not fit that textbook image we talked about earlier.
The single biggest blind spot is male patients. Men make up 10 to 25% of eating disorder cases, but they're consistently missed because the presentation looks different.
How does it look different?
In men, it is often driven by muscle dysmorphia. The psychological drive is not necessarily for thinness, but for extreme leanness. They want to be shredded. So you might see anabolic steroid abuse mixed right in with the restrictive eating behaviors.
So you have to look for an obsession with muscle definition rather than just pure weight loss.
Precisely. And another major high-risk population is pregnant patients.
That makes sense. The physiological toll must be massive.
It is extreme. They are at very high risk for severe postpartum depression. And interestingly, they have a much higher rate of requiring cesarean sections. The metabolic stress of pregnancy on a body with a history of an eating disorder is just immense.
Finally, we need to touch on the mimics, the differential diagnosis. You mentioned at the very beginning that we have to be careful not to just anchor on a psychiatric diagnosis immediately.
Right. Just because a young person presents with profound weight loss does not mean it is automatically anorexia. You must rule out organic causes first.
What are the big gastrointestinal mimics?
Inflammatory bowel disease is a major one. Celiac disease. Or superior mesenteric artery syndrome, which is fascinating. The severe weight loss actually causes the fat pad around the artery to disappear, so the artery literally clamps down and crushes the bowel, making them vomit when they eat.
And the endocrine mimics.
You have to rule out hyperthyroidism, which will drive rapid weight loss. Type 1 diabetes, Addison's disease. And of course, the most frightening one, malignancy. Occult cancers causing cachexia.
So diagnosing an eating disorder in the emergency department is really a diagnosis of exclusion.
It has to be. You have to ensure there is not a hidden tumor or a failing endocrine gland driving the entire process before you label it a psychiatric illness.
So bringing this all together, what does this mean for the clinician listening right now? We have gone from a vague, innocent complaint of feeling dizzy to recognizing a multi-system, life-threatening metabolic failure.
It means that when that patient walks into your bay, looking a little pale, complaining of just feeling faint, you do not just check their orthostatic vitals and send them home with instructions to drink more water. You look at their parotid glands, you inspect the back of their hands for Russell's sign, you ask the sexy off question.
And you immediately order an electrocardiogram.
You absolutely mandate an electrocardiogram. You have to look for that QT prolongation. Because the difference between sending that patient home and admitting them to a monitored bed could literally be a legal arrhythmia that happens in their sleep that very night.
Here is a final provocative thought for everyone to chew on as we finish. We spent a lot of time on refeeding syndrome, which implies that the absolute most dangerous time for the patient's heart might actually be the first week of their treatment when they finally start taking in calories.
That is the incredibly cruel irony of this disease. Recovery is a physiological tightrope. The heart is at its most structurally and electrically vulnerable when you're actively trying to fix the problem. It highlights that recovery is not just a psychological breakthrough, it is a rigorous, highly dangerous medical procedure.
That is a very powerful place to leave it. Be the clinician who looks at the knuckles. Use the SKOF tool on your very next shift.
And remember, you are never just treating a skinny patient. You are managing a critical metabolic crisis.
Thanks for joining us on this deep dive. We will see you all next time.